Welcome. We are really delighted to have you join us this afternoon for a talk and discussion on health equity with Dr. Brian Smedley. The events of this afternoon were coordinated by the College of Humanities and Sciences, the Black Education Association, and the Inclusion, Diversity, and Equity Committee of the College of Humanities and Sciences. Members of the planning committee from these units include Dr. Christopher Brooks from the Black Education Association, Christine Booker, faculty representative from IDEC, and Tyler Conrad and myself from the college. Our events will include a few words from our dean, a tribute to Dr. Audrey Smedley, and a talk by Dr. Brian Smedley. We will also have a question and answer period, so please put your questions in the question and answer box. Our dean, Jennifer Mallett, will provide us with some words next, a bit about Jennifer Mallett. She's the Dean of the College of Humanities and Sciences at Virginia Commonwealth University and a professor of sociology. Her research focuses on how health equity affects the health of people in the United States, and particularly how the systems of racial inequity affects patients and healthcare providers' perceptions of medical encounters. Personally, it has been a privilege to work with Jennifer, who has demonstrated a strong commitment to equity and inclusion in the college and at the university. Dean Mallett.
Thank you, Faye, and thanks for those kind words. I feel very fortunate that Faye recently joined the Dean team as the Associate Dean for Equity and Community Partnerships. As I'm sure many people attending this know, she is a strong scholar and mentor and advocate. So thank you, Faye, for that introduction and for joining us. And it's wonderful to see that we have over 200 people here joining us for this conversation. And I'm really pleased that the college is able to support this talk. The College of Humanities and Sciences has an important role to play in promoting understanding of health and illness and well-being, and in particular, COVID-19. As many of you know, I'm sure, biomedical factors are the direct causes of disease, but they are not the root of why people get sick and why people suffer disability and early mortality. Social factors are the fundamental causes of disease. And with 19 schools and departments in our college, with social sciences, humanities, and natural sciences all in our college, we have many researchers who focus on health as well as systems of inequality, making our college well positioned to play an important role in conversations that are taking place at VCU and in Richmond, the state, and in the country about understanding why we have health disparities and how we can deal with the particular challenges we're facing right now. So I'm very pleased to be welcoming Dr. Smedley. And since Faye gave me the introduction that says that this fits into my scholarship, I was really excited that he was coming because I already know his work. And I'm glad that he's here today to help us think through how the most recent threat to population health, COVID, is unfairly borne by Black and Brown people because of systematic exclusion from resources. I expect that his presentation will help us engage with questions about equity and ask us how we can use our professional positions and our daily practices to address these inequities and to help us understand what we're seeing happening with COVID. So thank you, Dr. Smedley, for joining us. And now I will go to Christopher Brooks, who will guide us in reflecting on the legacy of Dr. Audrey Smedley.
Thank you, Jennifer. My name is Christopher Brooks. I am a professor of anthropology in the College of Humanities and Sciences at VCU. And this is an honor and a privilege to reflect on our friend, Dr. Audrey Smedley. I'm also the president of the BEA, an organization that she was also very committed to during her time here at VCU, and I am pleased to make you aware of that. Dr. Audrey Smedley was born in Detroit in 1930 on October 31st. She was the eldest daughter of Ulysses and Mattie Smedley and named a scholarship here at VCU in their memory. Smedley was educated in Detroit public schools before receiving a scholarship to attend the University of Michigan. And that was one of several things that Audrey and I had in common, that both of us being University of Michigan alums. She graduated from Michigan in 1954 with a BA in History, Letters, and Law. She also received a Master's of Arts in Anthropology from Michigan in 1957 with a concentration in history. Smedley conducted field research on the social and economic organization of the Biram in northern Nigeria between 1959 and 1961. She earned a PhD in social anthropology from Victoria University of Manchester in the UK in 1967. While Dr. Smedley is best known for her scholarship on the history of the concept of race, an idea, according to her, that emerged in the Americas to justify chattel enslavement of Africans and the genocide of indigenous people, I first encountered the name Audrey Smedley in the mid-1980s as a doctoral student at the University of Texas at Austin. I came across an article that she had published in 1980 in the Journal of Comparative Family Studies. That article was entitled "The Implication of Biram Chichibiism." This was an incredibly informative article. Chichibiism, by the way, is a cultural practice where a married woman can take on a man as a lover, an escort, or something like this. And this is a practice that is still, or custom, I should say, still carried out among the Biram in Nigeria. I had no idea at the time that Audrey Smedley was an African American. I took note of her more because she was an Africanist who had done field research in Nigeria, and it was just a year before I began my field research in that country. Her book, Race in North America, Origin and Evolution of a Worldview, would establish her as a renowned scholar on the topic and would become her principal claim to fame. That work was the recipient of the 1993 Outstanding Book Award from the Gustavus Meyer Center for the Study of Human Rights in North America. In 2012, Race in North America was published in its fourth edition, along with Smedley's son, Brian, as co-author. Smedley's scholarship also appeared in the Encyclopedia Britannica, where she was the lead contributor to the publication section on race. She was also instrumental as the American Anthropological Association drafted its statement on race. In fact, she was also well known for examining race in the academy. In 2003, Smedley appeared in the California newsreel documentary film entitled Race, the Power of an Illusion. Prior to her arrival at VCU, there was another article that would inform my work, Race and the Construction of Human Identity. And that was in the American Anthropologist in 1996. In 2004, she published another major work, Women Creating Patrilineal, Gender and Environment in West Africa, which was based on her dissertation research among the Biram in Nigeria. In fact, I inherited several courses that she once taught here, including Introduction to African Societies, Women in Africa, which evolved into the current course, Gender and Culture in Africa and African Cultures. On a personal note, well, probably a professional note for that matter, Audrey came out of retirement in 2005 to serve on my promotion committee when I made a successful bid to the rank of professor. She told me at the time, once you get this promotion, you'll be the senior anthropologist in the program. I carried that responsibility with a lot of pride because that statement had come from her. After she moved to Silver Spring, Maryland with our dog, Jake the Rockwaller, I would visit and Jake was always thrilled to see me. Audrey and I routinely spoke, and she always made a point of telling me how proud she was of my scholarly output after she left Richmond. Faye, this is not to take anything away from your introduction of Brian, but he was here several years ago to give a lecture on campus. Whoever introduced him spoke about his achievement in this area and that area, but when he took the podium, the first thing Brian said was, I want to say that I am also the son of Audrey Smedley. Excuse me. That statement stuck with me because I thought at the time, how proud Audrey must be to hear that. We were, of course, totally bereft last year when we received the news of Audrey's death. It was not only because we lost a colleague and valued scholar, but many of us also lost a dear friend. But that said, the Audrey Smedley legacy continues. Not only because of her scholarship, but we're fortunate to have her son, the other Dr. Smedley, with us. With that, I would like to turn things over to my colleague, Faye Belgrave.
Thank you so much, Christopher, for that remembrance of Audrey Smedley. Just such a hero to all of us. And I was reminded of this proverb that I always say to myself. It's an African proverb that says, as long as you remember someone, they will never die. So I think of Audrey in that respect. It is my great privilege now, of course, to introduce Dr. Brian Smedley. Dr. Smedley is Chief of Psychology and the Public Interest at the American Psychological Association, where his efforts are to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. Dr. Smedley is a national thought leader in the field of health equity. Smedley got his start in Washington, D.C. as an APA Congressional Science Fellow and subsequently served at APA as Director of Public Interest Policy. Most recently, he was co-founder and executive director of the National Collaborative for Health Equity, a project that connects research, policy analysis, and communications with on-ground activism to advance health equity. He was also co-director of the Robert Wood Johnson Foundation Cultural of Health Leadership National Program Center. From 2008 to 2014, Smedley was vice president and director of the Health Policy Institute of the Joint Center for Political and Economic Studies in Washington, D.C., a research and policy organization focused on addressing the needs of communities of color. Dr. Smedley was also a senior program officer at the Institute of Medicine, where he served as study director for the well-known reports coming from IOM on nation's compelling interest in ensuring diversity in the healthcare workforce. And also, I cited this paper again and again, Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. among many other reports on diversity in the health professions and minority health. Many, many awards and distinctions. I won't go through them all. In 2013, he received the American Public Health Association's Cornea Award for Social Activism. In 2009, he received the Congressional Black Caucus Congressional Leadership Advocacy Award. In 2005, he received a presidential citation from the APA. There's just too many to report at this point, but we all know that Dr. Smedley is a very esteemed person. He certainly published seminal papers and books on the topics of race and health equity, including the one that Dr. Brooks mentioned with Audrey Smedley on race in North America, which has been cited numerous times. But beyond all these accolades and professional accomplishments, I can say something about him as a professional colleague whom I've known for over, I think, 25 years. Brian is genuine, collaborative, and simply one of the nicest persons I have had the pleasure to work with. And as we say at VCU, he keeps it real. We are thrilled to have him join us today. And just before Brian begins his talk, I wanted to have people know that they can put questions and answers, questions in the box, and then we will have Dr. Smedley respond to these after his talk. Dr. Smedley.
Thanks so much, Dr. Belgrave, Dr. Brooks. Good to see you both again. Dean Mallett, it's great to meet you. I thank you all for having me. I've always considered VCU as part of my family. Back when my mom came out of retirement to work at VCU, I thought, why would you do this, Mom? But she loved to teach. She loved scholarship. She loved students. And she was deeply committed to VCU. So I thank you so much. I want to start by telling a story about my mother and VCU, but it's more about VCU than my mother. I'll start with just noting that my mother was not a sports fan at all. Did not know what was going on in terms of current things going on in the sporting world, things like that. VCU was kind enough to invite my mother back to campus in April of 2011 to speak on campus about her scholarship, about the concept of race. So I drove her down there. At that point, she was driving a little bit less. She was in her early 80s at the time. And we drove down to the campus from the DC area. And the first thing I noticed was that the campus was just electric. People were buzzing, people were wearing their black and gold, and the whole campus just was excited and abuzz. And those of you who are sports fans will remember that back in April of 2011, the VCU men's basketball team made it to the Final Four. My mother didn't know that. So when we drove to the campus and I saw how excited and electric the place was, I immediately began to worry, would any students show up for my mother's lecture? It was a lecture to be held in the early evening, and there was a lot going on campus, pep rallies, things like that. So we got to the lecture hall, and I thought to myself, how am I going to explain to my mom if there's only 3 or 4 people in the audience that there's other things going on? And as important as her scholarship is, people are excited about the men's basketball team. So we get to the arena, to the lecture hall, and it was packed. It was absolutely packed. And I thought to myself, wow, this must be where the pep rally is. I was looking for the men's basketball team. I was looking for the coach. I didn't see him anywhere. They were there to hear her. That says something remarkable about VCU and the VCU family. So I want to thank you all again for remembering her. I want to share some slides if I can. And I want to just begin with something that Dean Mallett observed. During the COVID pandemic, it became immediately apparent that many of the racial and ethnic inequities that have been deeply baked into our nation, pre-existing conditions, if you will, were being exacerbated by this pandemic spread. In fact, the pandemic was more of a syndemic, a pandemic that was accelerated by social and economic inequality, racism, and the deep divisions of our society. So when it became clear in the spring last year that communities of color were more deeply affected by the COVID pandemic, that was no surprise to those of us, Dean Mallet and others who study health equity, why this was. Clearly, this kind of syndemic will ravage communities that are marginalized politically, economically, socially. So as news reports began to emerge about the COVID pandemic, one of the things that was very frustrating to me to hear was that news reports explained that Black and Brown people were more at risk for mortality and bad outcomes if infected because of pre-existing chronic conditions. Well, why do those pre-existing chronic conditions exist? They exist not because of any source of genetic or biological deficiency on their part, rather because of our society, how we organize our society, how we allow racism and other sources of the belief in human hierarchy to persist. So I'm going to go ahead and start my slideshow. And I would like you to uh, go with me through a little journey, and in part through our history, to understand how we got to this point where we see deep inequities existing prior to the pandemic, exacerbated during the pandemic, and sadly, they will persist after the pandemic. But it's my deep hope that this pandemic represents an inflection point for our nation. We can't emerge as a healthy, productive nation from this pandemic without a recognition that our deep divisions are helping to fuel it. It's my firm belief that that's why the United States has 20% of the world's mortality due to COVID, but only 4% of the world's population. It's because in societies that are characterized by deep division and discord, this is what we get. We get a pandemic that spreads deeply and broadly, and of course, it affects all of us. Even though it disproportionately affects communities of color, it is definitely hurting all of us. So let me just start with a brief mention about the way I frame these issues. And before I jump into this, I want to acknowledge that though my relationship with VCU ended when my mom retired, I continued to work with great colleagues at VCU. I'm so blessed to work with Dr. Nao Hajawara in the Department of Psychology. And I've had a long-standing, wonderful collaboration with the VCU Center on Society and Health, headed by Dr. Derek Chapman and formerly Dr. Steve Wolf. And I'm going to provide some examples in this talk of the great work that the Center on Society and Health does, because in the process of collaborating with them, they have been key allies in helping me to articulate the importance of place and its relationship to race, racism, and health. So to start, we all need to recognize that there is a geography of opportunity in the United States. The spaces and places that we occupy are not equal, and they are in fact racialized spaces. The spaces occupied by people of color tend to have a disproportionate concentration of health risks, a relative lack of health enhancing resources. And I've devoted much of my career to attempting to uncover these kinds of mechanisms and to undo the consequences of racism for health. I particularly have focused in recent years on the role of residential segregation as a key driver of health inequities. And this may be surprising to some. The reality is that segregation persists in our schools, in our neighborhoods, and has important consequences for economic opportunity and life chances in our country, in addition to shaping opportunities for health and well-being. We've made a lot of progress in the United States in desegregating our communities. We no longer have, of course, Jim Crow laws on the books, and some of the relics of the past, such as sundown towns, hopefully are just that. But unfortunately, segregation persists in ways that continue to constrain opportunity for many people of color. We have a myth in this country that people can live anywhere that they choose to if you have the economic means. And we tend to think that segregation arises from the unintended consequences of economic forces. So the fact that Black and brown people and Native people tend to have lower incomes, lower wealth, many would tend to shrug their shoulders and offer those as explanations for why we have segregated communities. But the reality is, if you've read Richard Rothstein's wonderful book, The Color of Law, our government at all levels, federal, state, and local, has been complicit in creating segregated spaces in ways that carry on to this day. So the legacy of segregation persists. And I'm going to show some data on how segregation continues to play out. But in terms of how segregation was established, we need to be clear that government had a very clear role through things like undisguised racial zoning. Up until 1964, homeowners could apply racial covenants, religious covenants to their properties, whereby they could not sell to racial or religious minorities. There have been efforts by governments to create public housing that has been purposefully placed in already high poverty segregated neighborhoods, keeping lower income families out of wealthier and wider neighborhoods. Our governments have created subsidies for builders to create whites-only suburbs. Many of you know that there are some very famous suburbs, such as Levittown in the New York suburbs, that was created by a developer with the assistance and backing of the US federal government. And the vast majority of homes in Levittown after World War II were sold to white GIs with the benefit of the GI Bill. GIs of color could not take advantage of those same opportunities. So government was very complicit in creating those whites-only suburbs. Government offered tax exemptions for institutions that enforced segregation. And of course, government stood by while there was often violent resistance to African Americans attempting to integrate into all-white neighborhoods. So the myth that we live where we choose to, or that segregation arises because of income inequality or wealth inequality, is simply that. It's a myth. The consequences of government action to segregate and to exclude and isolate communities from mainstream economic opportunities persist to this day. Many of you are familiar with the concept of redlining, whereby the federal government backed home mortgages, but only in certain communities, only in those communities that were considered low risk. And those communities on maps of different cities around the country were shaded in green or blue, indicating that they were considered safe for investment. Those communities that were shaded red were not considered safe for investment, and often those communities not only were denied home mortgage loan backing, but that signaled to other investors that they should not invest in those communities either. Those communities, disproportionately African American and low income. Today, 3 out of 4 of the neighborhoods that were redlined on government maps 80 years ago continue to struggle economically because of that shutting off of the spigot of investment from private investors. Nationally, nearly 2/3 of neighborhoods deemed to be hazardous in the 1930s are inhabited by mostly people of color. Cities with more of these neighborhoods have significantly greater income inequality to this day. Again, the legacy of redlining lives on. On the flip side, 91% of those areas that were classified as best over 80 years ago remain middle to upper income today, and 85% of those communities remain predominantly white. So those actions 80 years ago have ripple effects, and the legacy of segregation as a result of government action persists. Demographers have long been interested in studying the level of segregation in different communities, different countries. These are data provided by researchers such as Doug Massey and Jim Fry. They're using a measure called the Dissimilarity Index, which is simply the percentage of 2 population groups that would need to move to create complete integration within a defined geographic area. So as you can see from the bar on the far left here, South Africa, back in 1991, prior to the dismantling of apartheid, had a dissimilarity index of 90, meaning that 90% of Black and white South Africans would need to move to create integration in that country. And that, of course, was the point of apartheid, to keep those groups separate. But did you know that as late as 2010, several major US cities were not far behind the level of segregation in South Africa prior to the dismantling of apartheid. So Detroit, Milwaukee, New York, Chicago, Newark, all of these cities had dissimilarity indices of 80 or higher, meaning that 4 out of every 5 Black and white residents of those cities would need to move to create complete integration in those communities. Why am I emphasizing the role of segregation? Well, we know that there are several important consequences of segregation, particularly for health and human development, and particularly for young kids. We know that segregation tends to concentrate poverty, and it excludes and isolates communities of color from mainstream resources needed for success, such as access to good schools, access to jobs, access to capital to start a business. Many in highly segregated communities of color simply do not have these access to these opportunities for economic development. And it is true today that many people of color are more likely to reside in poorer neighborhoods regardless of their own income. I hope to show an example of this shortly. Segregation restricts socioeconomic opportunity to the extent that kids of color are limited to public schools where that lack the resources to help these students achieve their highest educational attainment and to go on to higher education. This remains a consistent problem in communities around the country. Why is this happening? Because the local tax dollars that are often used to support local public schools are deeply suppressed in highly segregated communities. These are also communities with fewer employment opportunities and, importantly, smaller returns on real estate. This is the factor that helps explain the significant and growing wealth gap between white and Black and white and Latino families in this country. Historically, white families have been able to take advantage of the Levittowns of our country. Homes that could be purchased in Levittown post World War II for $4,000 sell now for $400,000 and up today. That kind of wealth, those families were able to pass along to their descendants, and families of color were rarely afforded such opportunities. We also know that segregation tends to shape the retail food environment. African Americans are 5 times less likely than whites to live in a census tract with a supermarket, are more likely to live in neighborhoods with a high concentration of vendors selling unhealthy food, such as fast food, products that are high in fat, sodium, and sugar. There's disproportionate liquor and alcohol advertising and sales, and of course, convenience stores. Taken together, that means the retail food environment in many highly segregated communities of color simply does not allow for families to take advantage of nutritious food options in those communities. This was true for many years in my hometown of Detroit. Detroit for many years did not have a grocery store in the 1990s, did not have a single grocery store within the city limits. There are some now, and I'll talk a bit shortly about some of the federal initiatives that have incentivized grocery stores to come into these so-called food deserts. We know that Black and Latino neighborhoods also tend to have fewer places for active lifestyles, for recreation and play. They have fewer parks, fewer green spaces, fewer tree canopies, fewer safe places to walk, jog, bike, or play, fewer rec centers, fewer swimming pools. And these are some of the very factors that facilitate active lifestyles. Taken together, the fact that we have poor retail food environments and a poor infrastructure for active lifestyles means that all the finger waving that we've done and moralizing that we've done about active living and healthy lifestyles, that simply does not take into account the context in which many people live in highly segregated communities. We also know that these communities are more likely to be exposed to environmental hazards, such as polluting industries. We know that in 2004, 56% of people who lived in neighborhoods with commercial hazardous waste facilities were people of color, even though at the time they were only about 30% of the US population. And then there's the poverty tax. People in poor communities pay more for the same goods and services as people in higher income communities. So you pay more for auto insurance, you pay more for furniture, you pay more for bank fees, and that's if you can find a bank. Many of these communities are literally unbanked. You cannot find a bank branch in those communities, which further constrains economic mobility. Now, the real issue here is not that people of the same race or ethnicity are living together. It's the fact that in highly segregated communities, we have effectively concentrated poverty. And as a government policy, this was very effective in conflating race and poverty. We've done some research a few years back when I was at the Joint Center on the increase in the number of high poverty neighborhoods around our country. And even though these data are a little bit old, they're still very alarming because we saw a sharp uptick in the share of people living in medium poverty neighborhoods. Those are neighborhoods where between 20 and 30% of the population in a census tract is below the poverty line. At that time, there were nearly 30 million people living in those medium poverty tracts. In terms of high poverty tracts, where 30% or more of the residents lived below the poverty line, by 2009, we had 20 million people living in those high poverty tracts. When we talk about extreme poverty, neighborhoods where 40% or more of the residents live below the poverty line, again, we see a sharp uptick following a promising decline in the share of these neighborhoods from 1990 to 2000. So I'm very curious to see where we are today once the 2020 census data are released. It's also true that people of color are disproportionately concentrated in high poverty census tracts. These are data showing the share of white, African American, Asian American, American Indian, and Latinx populations in our nation's metropolitan areas, broken down by the type of neighborhood that they're living in, given the share of poverty concentration. The bar on the far left shows the share of white Americans in high, medium, and low to moderate poverty concentration census tracts. As you can see, about 90% of white Americans are living in low poverty tracts. Contrast that with the 55% of African Americans who live in low poverty tracts. The remaining 45% are in medium or high poverty census tracts. Same is true for Asian Americans, American Indians, and the Latinx population. All of these groups are disproportionately concentrated in medium and high poverty tracts. Again, a legacy of our state-sanctioned process of sorting and separating people into different neighborhoods. Now, here's a slide that I find stunning to this day. We can control for differences in income and still see dramatic differences in terms of where different racial and ethnic groups live. So these are the share of poor Black, Hispanic, and white residents living in census tracts with different levels of poverty concentration. So if you look at the set of bars on the far left, this is the share of poor white, African American, and Latinx families living in low to moderate poverty census tracts. As you can see, of these poor Americans, about 70% of whites are in low poverty tracts compared to about a third of poor African Americans and 40% of poor Latinx families. When we look at the share in medium and high poverty tracts, clearly a greater share of poor Black and Hispanic families are in those census tracts as opposed to poor white families. Why does this happen? Again, this is the result of our legacy of racial residential segregation. We have effectively provided many more housing opportunities for low-income white families, and they are not concentrated in poor census tracts as poor people of color tend to be. So in addition to differences in lived experience based on skin color, we also have this deep structural inequity in that if you're going to be poor, you better hope that you're white, because you're much more likely to be in a high poverty census tract if you are a family of color. I want to show an example of one of the maps that the VCU Center on Society and Health created for us back a few years ago. Here we're looking at a dot density map, which simply shows the share of the population in Baltimore, Maryland, living in different parts of the city. The blue dots represent 50 white residents. The purple dots represent 50 African American residents. Orange is Latinx, green is Asian American, and you don't need to be a demographer with fancy statistics such as the Dissimilarity Index to see that Baltimore is a deeply segregated city. Please keep this pattern in mind as you look at this map. again, created by my friends at the VCU Center on Society and Health, which shows life expectancy across different census tracts in Baltimore. As you can see, those tracts that are shaded in the darker brown or rust color have the lowest life expectancy, whereas those tracts that are in the pale yellow have the highest life expectancy. One of the census tracts in Baltimore near the Midtown area had a life expectancy of around 57 years of age, comparable to developing countries. Whereas other tracts in Baltimore, in some of these other tracts, you can expect to live to be about 86, nearly a 30-year difference in life expectancy across these neighborhoods that are in some cases just a few miles apart. What explains that difference? Access to health care? Differences in health behavior? No, it's how we've structured opportunity based on racial residential segregation and redlining. Because as you'll see in this map, those neighborhoods that were formerly redlined in Baltimore, as you can see on the map on the left, that's an old Federal Home Ownership Loan Corporation map, corresponds geographically to those neighborhoods that have been persistently in high poverty over many decades. So the map on the right shows, and those that are shaded in brown are tracts that have shown high poverty over many, many decades, dating back to the 1970s. Whereas those tracts that are shaded in yellow have no such history of deep poverty concentration. So again, we can see the legacy of that policy decision continuing to play out today. I've talked a lot about what the problem is. How do we begin to fix it? What does the science tell us about where we should turn for solutions? Well, there's several themes that emerge from the literature. One is that we should be focused on prevention, and particularly focus on the conditions in which people live, work, study, and play. We need multiple strategies across many sectors. I hope it's apparent from what I've described before that we need to be working across sectors such as the food industry, the real estate industry. We need to be talking and engaging with those industries that are polluting industries, and to be working with government agencies across all sectors. These are not problems that are limited to healthcare, the healthcare sector, or to public health. We need to engage with those agencies and departments responsible for the environment, for transportation, for housing, for education. All of these are determinants of health. And we need a sustained investment in a long-term policy agenda. I hope it's clear from the brief history that I've reviewed that we didn't enter into these problems overnight. They took 400 years to create. Similarly, we will not solve them or in 2 or 4 years or by the next election cycle. We need a sustained long-term investment to begin to undo the consequences of these policy actions that created and conflated race with poverty. There are 2 general buckets of strategies that I focused on and have worked very closely with communities to see if we can build support for these kinds of strategies. The first bucket of strategies are place-based interventions, such as investments in communities that can reduce the concentration of health risks in communities of color while increasing access to health-enhancing resources. And I'll say more about that in a second. The second bucket are people-based strategies, such as investing in early childhood education. We know that when we invest in the educational enrichment early on of kids who are at risk, whether living in high poverty neighborhoods or living in a family that is itself low income, that we improve the odds for these kids dramatically. There have been a number of longitudinal studies following kids from birth to adulthood, and they find that when we've invested in early childhood education, these children do much better than control groups of children who had no such early educational enrichment. They tend to have better occupational histories, better educational attainment, better income, etc. But we also need to do other things, and I hope it's clear from what I've said that housing is a big part of the solution. We believe in investing in housing mobility to give people true choice into where they may seek to live. So I'm going to talk about some of these strategies in greater detail, starting with place-based investments, creating healthier communities. We know that we can improve the retail food environment in communities. For example, I mentioned that Detroit for many years did not have a major grocery store within its city limits for many, many years in the late 90s. Now there are many grocery stores, in part thanks to financial offered by federal and state governments, such as the Federal Fresh Food Financing Initiative, which creates both tax incentives as well as other kind of regulatory and land use incentives so that grocery chains will want to place their stores in so-called food deserts. We can also do things like helping mom and pop grocery stores to have refrigerated products such as produce that can be available. And we can regulate the placement of non-nutritious food sources, as well as other products that can be harmful, such as liquor and tobacco stores. We can also structure land use and zoning to reduce the concentration of health risks. One of the best examples that I've seen of this comes from the County Council of Los Angeles, which observed that South Los Angeles, many parts of that community have been food deserts for years. So that county has decided that they will no longer issue permits for fast food restaurants or corner stores or other vendors selling unhealthy products, and rather they're investing in sit-down restaurants and other healthy nutrition options. Other governments, state, local, federal, are using tools like health impact assessments to determine the health consequences of decisions that are made in areas outside of health. So decisions made around housing, transportation, education often have important health consequences because these are the determinants of health. Health impact assessments simply helps policymakers to understand what those consequences might be they positive or negative, so that we can anticipate them, understand how to make smart policies that will help these communities create healthier communities. There are other strategies that communities can employ. Activists are working to improve air quality. One of the best examples I'm aware of comes from New York City, where activists noticed that there was a high concentration of respiratory disease and asthma in parts of West Harlem and other areas that were already poor. Well, it also happened that the city's bus depots were there. So when city bus drivers would go to those bus depots in the morning, they would turn on the ignition in the bus and idle the bus to warm them up. Well, that resulted in a high concentration of diesel exhaust and other particulate matter in those neighborhoods. Working with the city, those advocates were able to map the geographic correspondence of childhood asthma cases with where those bus depots were located, and they worked with the city to disperse those bus depots away from neighborhoods, away from children, and to employ greener practices so that they could reduce respiratory risk. We can also expand the availability of open space, and we can encourage exercise in pedestrian-friendly communities so that people can use active means of transportation to get to where they need to go. And we can address disproportionate environmental impacts, doing things like brownfields redevelopment. And this is needed around the country. We can think about examples such as the tragic example in Flint, Michigan, where government officials switched the water source from the Detroit River to the Flint River and did not take the steps to test the water to ensure that it would be safe. Sadly, thousands of Flint children, disproportionately low-income and African-American, were exposed to lead in that process. And sadly, Flint is not the only example that we have around the country of this kind of environmental assault. Let me now turn my attention to people-based strategies, and in particular, housing mobility. Simply the notion that we can help people to move to healthier, safer neighborhoods if they so choose. And I want to turn to the Moving to Opportunity study, which was sponsored by the Department of Housing and Urban Development. This was a 10-year randomized controlled trial to test the effects of moving from high to low poverty neighborhoods on the health, well-being, and economic outcomes of low-income families. Now, sadly, this kind of experiment can be done because there are thousands upon tens of thousands of families waiting for portable housing vouchers, Section 8 housing vouchers, to help supplement their income so that they can afford to pay for rental housing. Well, those Section 8 housing vouchers are disproportionately used in already poor neighborhoods. So low-income families that receive these vouchers tend to stay in low-income neighborhoods. But because so many families were on waiting lists and continue to be on waiting lists to this day, researchers were able to create this randomized controlled trial, which allowed them to create experimental group as well as a control group. So when this study began in the 1990s, nearly 5,000 families were enrolled into this study and were randomly assigned to one of three groups. The first was an experimental group that not only received housing vouchers, but they also received special assistance and counseling to help them find rental housing that would accept their vouchers in low poverty neighborhoods, in effect helping move from high to low poverty neighborhoods. A second group received vouchers that could be used anywhere, but no counseling. And as a result, many tended to stay in high poverty neighborhoods because they simply didn't know about other options that were available to them or were not afforded those opportunities. A third control group didn't receive vouchers but remained eligible for other government assistance that they might otherwise be eligible for. There were 5 studies in this RCT: Baltimore, Boston, Chicago, LA, and New York. Upon 10-year follow-up, investigators noted a number of important benefits. Parents and families who moved from high to low poverty neighborhoods had lower rates of severe obesity and depression and reported lower levels of stress. Lower poverty neighborhoods also tended to significantly improve college attendance rates and earnings for children who moved from high to low poverty neighborhoods, but primarily when they were young. Children who were older, adolescents and teens, did not tend to benefit as much from those moves. Those children also were less likely to become single parents as they got older. And the treatment effects were substantial. Those families that moved from high to low poverty neighborhoods had over 30% higher incomes relative to the control group. In contrast, those same moves had negative long-term impacts on children who were older, 13 years or older, perhaps because of the disruptive effects of moving from those neighborhoods. So many cautions emerge from this research. First, housing mobility is not a panacea. We know that we need comprehensive strategies to reduce stressful and unhealthy conditions in poverty neighborhoods, but wholesale dislocation is not effective. Sadly, we have seen too many instances, natural experiments, if you will, where we saw the disruptive effects on communities of color of being moved. So under the guise of urban renewal, under the guise of big public transportation projects, many communities of color have been displaced, too often with highly negative consequences because of the disruption of social ties and social relationships. Social cohesion eroded as a result. So people-based interventions such as housing mobility should always be accompanied by place-based interventions to stimulate economic activity and improve community conditions in these under-resourced neighborhoods. It's a both and, not an either or. And again, housing mobility should be for those who choose to move out of their neighborhood. I should add, though, that it's also true that when we see investments in communities, often that is followed by displacement of people who've been living there. So when we bring in amenities to a neighborhood, restaurants, places for walking, parks, etc., what happens? Those neighborhoods tend to gentrify. So part of the power of housing mobility is giving people the power and the choice to stay in their neighborhood if they so choose. So rather than being displaced, housing mobility implies that portable housing vouchers can be used to help those families that choose to stay in the neighborhood of origin rather than being displaced by these processes. I want to just say this is my family. You all remember Audrey Smedley right here, surrounded by her family. This is her brother, Laconia Smedley, her late sister, Miriam Smedley, my wife, Carla. It's my brother, David Smedley, and the rest of our gang. That's my daughter, Avery. It's my son, David. As you can see, like a lot of Black families, we range in complexion from peach to chocolate. And one of the things my mother always taught me is don't let anybody define who you are. Who you are is in your head and your heart. So I have long lived with the privilege of being a light-skinned male. I know that that carries privilege. I joke with my friends that I may be one of the few brothers who can get a cab on a busy New York City street. And with that privilege comes responsibility. I thank my mother for teaching me that. Thank you. I'll be happy to take any questions that you may have.
Thank you. Thank you so much, Dr. Smedley, for this talk. And just want to really say how much we appreciate you taking us back to the historical context of the segregation that led to what we see today, and also for your very thorough examination of different types of strategy. There's no one answer here, and we really appreciate that. So we do have time for questions, as Dr. Smedley mentioned, and I know there are questions in the chat box, and so we're going to ask Dr. Christine Booker if she will read the questions and have you answer them. And I hope we can get through many, because questions are starting to pile up a little bit. So we'll just get through as many as we can. Okay, Christine?
Thank you. I want to echo Dr. Belgrave's comments and want to thank you, Dr. Smedley, for that informative and stimulating presentation. The first question is, knowing your diverse background combating health inequities, do you believe the confluence towards telemedicine presents a unique opportunity towards the decreasing of Black, Indigenous, people of color related biases within healthcare?
That is such a great question. You know, the pandemic has brought about many terrible things, but it's also showed us perhaps what the future will bring. And telemedicine is one of those. In the space that I work in currently in the mental health space, we call it telemental health. And one of the things that we know is true in the mental health arena, it's also true in healthcare, is that we have a fundamental maldistribution of resources relative to community need. What do I mean by that? Well, we have a market-based healthcare system, and the best and most resources are going to go to those communities that can afford it. So we consistently see that there are medical shortage areas, medically underserved areas, and those are disproportionately communities of color. So I'm actually excited by the potential of telemedicine, with some caveats, to be helpful as an equity enhancing vehicle. Part of the challenge that we have with this maldistribution of healthcare resources is that for communities of color, we can often see many geographic, financial, cultural, and linguistic barriers to accessing healthcare. But with telemedicine, we increase the options that are available to people of color who want to receive services, whether they be general health services or mental health services. So as opposed to the days of old, where let's say you were looking for a mental health provider that shares your cultural and linguistic background, you had to hope that you had a provider in your community that you could get to, and one who you could afford, whether you have insurance or not. Today with telehealth, you're no longer constrained to your geographic community. You can find services in language, you can find services from a provider with your cultural background. And so that to me is exciting, because that helps to ensure that this part of this maldistribution can be addressed. But it's also true that we face significant shortages of providers of color. Again, a fundamental challenge, and again, a result of the deep racialized inequities that we have created in this country as a matter of public policy. So that piece has to be solved. We have to ensure that we have a pipeline of diverse providers who are well-trained and well-equipped to treat diverse populations. The challenge, of course, is that in many instances, telehealth services or telemental health require broadband access or access to technology that many communities of color and rural communities simply don't have access to. So on the one hand, we have the promise and potential that telehealth services can advance equity in healthcare. It doesn't solve it completely, in my view. And the questioner asks about the question of bias. I believe all of us harbor bias, including our doctors, nurses, psychologists, dentists. All of us harbor bias. If you've been socialized in the United States, you have been exposed to deeply racialized myths about human hierarchy. And we have to be consciously aware of those biases, many of which are implicitly held. They may not be explicit. So telehealth solves some of our challenges regarding geographic, cultural, and linguistic access, but it doesn't necessarily solve the problem of bias, and it sure doesn't solve the problem of the maldistribution generally of our healthcare resources. Thank you for that question.
Thank you. The next question is, are Black communities also pharmacy deserts?
Yes. Not only are Black communities pharmacy deserts, but we also know from some recent research that in many cases, the kinds of medicines that folks might need are not carried in the pharmacies that are present in African American communities. One study found that pharmacies in segregated communities of color were less likely to carry pain-killing medications, which mirrors a national problem in that we see that Black and Latinx patients who are in pain are less likely to be prescribed pain medications than white patients who are experiencing similar injury. So we have that's a problem of bias. And we have that problem compounded by a structural inequity, which is the distribution, again, of a vital healthcare resource, in this case, pharmacies, and the maldistribution, the fact that communities of color are less likely to have these pharmacies in the community. And in some cases, those pharmacies are less likely to carry the kinds of medications that patients need. So we got to address these multiple problems simultaneously.
Thanks. All right, the next question. Can you share your thoughts about charter schools benefiting privileged communities at the expense of public schools in minority communities?
That's a great question, and I need to tread carefully because education policy is not my arena. But I'm deeply troubled by the inequities in our educational systems, and I see inequity growing. Many of you know that despite the 1954 Brown versus Board of Education Supreme Court decision, we've not made very much progress on the issue of desegregating our schools. And in fact, we have gone backwards since the 1970s. There's evidence that kids of color are much more likely to be found in majority minority schools or are increasingly likely to be found in majority minority schools relative to white kids. So white kids and kids of color are just not interacting in our public schools. That should be deeply troubling to all of us because all of these kids are hurt by that. I would argue that those white kids are hurt because they're not exposed to difference. They're not exposed to the kinds of rich discussions based on different cultural backgrounds that will help them to succeed regardless of what type of work they want to go into later in life. It is going to be critically important for all of us and all of our white children to be culturally competent going forward. Whether you're a business person, a lawyer, a physician, you have to learn to manage difference in your life. And those who are most effective in embracing difference are going to be more successful. So I worry about that. And I worry that our kids of color, because they are increasingly concentrated in majority minority schools, face a structural inequity. That is a resource problem. Those schools that are majority minority, you can bet that those are schools that are also spending less per pupil than wealthier and whiter schools and school districts. These are schools where kids are being taught by teachers, in some cases without credentials, to teach in the subjects that they're teaching in. In many cases, the physical infrastructure of those schools is crumbling. We have outdated textbooks. This is the kind of inequity that's going to hurt all of us because we're leaving these kids of color behind and disadvantaging white children who are not exposed to cultural differences. Over half of our young people under 18 in this country today are kids of color. This is our future, and we need to invest in these young people. So I find it troubling to see any kind of policy that would tend to further segregate us on the basis of race, ethnicity, or income. We need to find ways to integrate our schools and to make them the rich multicultural interaction that we know our larger society is. So while I can't comment on charter schools per se, anything that would tend to reinforce the existing status quo of separate and unequal is deeply worrisome to me. So I will leave it at that. Thank you.
All right, this question refers to the regulation in the presentation. It says, what kind of regulation of liquor stores, and would these be the same regulations as in white neighborhoods?
So the notion here around whether you're talking about liquor stores, outlets selling other harmful products, be they high fat, high sodium, high sugar food products. The notion is that we can't saturate communities with these kinds of vendors and leave them without other healthy options. And so local jurisdictions around the country are taking notice of this problem, and they're beginning to establish policies that would cap or limit the number of vendors in a community selling harmful products, and that would apply in the case of liquor stores as well. So the question asks, are regulations different in communities of color versus white communities? That I don't know the answer to, but I do know that communities of color are often overrun with these kinds of vendors, and we have done little to check the saturation of these kinds of stores in communities of color, because that powerfully shapes what is bought, what is sold, what is considered appealing to consumers. And so we have to be very clear that, while we are a nation that cherishes the notion of freedom and business owners being free to open a store where they would like, we have to also recognize and balance that against community well-being. And community well-being, to me, suggests a more active role in regulating where these kinds of vendors can establish their businesses.
Thank you. We have an attendee who's sharing some of his background. So it says the data continuously shows how people are practically forced into these poverty tracks where we see bad health outcomes. As someone who has personally lived in these neighborhoods, I see convenience and liquor stores profit tremendously in these communities without investing back into the very communities they profit from. I personally believe that stakeholders such as convenience stores specifically and all those predatory entities in our communities should be held accountable to addressing this issue of food insecurity and other determinants. My question is, without the political will of our city leaders to implement effective strategies to improve these neighborhoods without gentrification methods, how can poor and working class folks make these changes to deconstruct poverty and improve their health outcomes? Thank you.
Oh, wow. What a wonderful question. Thank you for that. It suggests a lot of strategy. I actually hadn't thought about this until this question, but it suggests that there is a lot that communities can do to harness their own power to shape the retail environment in ways that they see fit. So what would happen if communities decided we're not going to continue to patronize a convenience store that's selling cigarettes and soda pop and pork rinds and is doing little for community uplift? What if those kinds of stores were no longer patronized by community members? What if community leaders began to organize to help people to demand that our elected officials take seriously their responsibilities around zoning and regulation to ensure that these communities have the kinds of vendors that they want in their communities, as opposed to the vendors that are frankly predatory, as the questioner suggests. I'm all for community-driven solutions, and particularly instances where communities harness their power, because they have power. They have sources of strength and resiliency, regardless of the demographics, regardless of the income level, and where communities demand that they be respected, including by those that would do business in their communities. I think that is a very, very powerful thing. I thank the questioner because I've learned a lot from that question.
Thank you. All right, the next attendee is thanking you for your presentation. Researchers are examining the relationship between social determinants of health and subsequent outcomes. Recently, Daniel Dawes has introduced the political determinants of health. Both types of determinants are very much socially constructed, as is race. It seems that health inequities research would benefit by incorporating standard measures of systemic and structural racism when examining health and health outcomes. What are your thoughts on this? What are some strategies that can be used to move needle of research to include these measures in their studies?
Such a wonderful question. First, I want to give credit and tip my hat to my friend Daniel Dawes. The political determinants of health is exactly right. We talk about the social determinants as if they're just these social forces, but they're often shaped by politics and policy. So much of what I've talked about here are things that Daniel would consider political determinants of health, such as the fact that we've never come to grips with our history of state-sanctioned forms of segregation. That was a policy, that was a political determinant of health that reverberates to this day. The other part of the question that I really like, and that one that I've been focused on in much of my career and research is a much more sophisticated understanding of racism and how it operates. It's been gratifying to see a change in the conversation about racism in this country. People are talking about systemic racism. But what is that? What does that mean when we talk about systemic racism? Dr. Kamara Jones says racism is a system that assigns value based on what we look like and what we associate with race in this country, advantaging people of European descent while disadvantaging people of color and ultimately undermining the whole society because of the waste of human resources. So I agree with Dr. Jones. Racism is a system, but it operates at multiple levels. We're aware of interpersonal racism. We know what that looks like. When a person in a position of power and privilege uses that power and privilege combined with racist ideology, the belief in the superiority of people of European descent, to further suppress people of color. Well, that's true, and we need to intervene to the best we can and to mitigate and ultimately eradicate that form of racism. But one of the consequences of that form of racism is internalized racism. Internalized racism refers to the acceptance by marginalized populations of dominant views of their inferiority. And we see this playing out in many settings. Over 80 years ago, the psychologist Dr. Kenneth Clark and his wife, Dr. Mamie Clark, conducted the infamous doll study tests, where they showed brown and white dolls to African American and white children. They asked these children, which is the nice doll? Which is the pretty doll? Which doll do you want to play with? Invariably, all those kids said that they thought the white doll was the nice doll, the pretty doll, the one they wanted to play with. And when the Clarks asked, which doll looks most like you? They noted the deep feelings of shame and inferiority that these very, very young kids of color had about themselves. That is deeply damaging to health and mental health. So those two forms of racism are persistent and need to be addressed. But unless we address two other forms of racism, we're not going to move the ball on internalized or interpersonal forms of racism. And those are institutional forms of racism, policies and practices of organizations, systems, institutions that perpetuate racial inequality. What are examples of this? Aggressive policing in communities of color as a matter of policy disproportionately exposes people of color to risks directly at the hands of police, and secondarily to terrorism. We have many instances of young people with post-traumatic stress disorder as a result of aggressive policing in their communities. Educational systems that employ draconian school disciplinary policies. These kinds of disciplinary policies disproportionately hurt kids of color and fuels the so-called school to prison pipeline to the extent that those disciplinary policies force out kids of color. That's a form of institutional racism. These policies and practices are always neutral on their face with respect to race, but almost always lead to racial disparities in their outcomes. We see institutional forms of racism in healthcare settings that don't address bias in those settings, et cetera, et cetera. There are many examples. And then we have structural forms of racism. which are, in my view, most closely linked to the political determinants of health that Daniel talks about. Structural forms of racism are policies, practices, cultural narratives, and myths that reproduce racial inequality, and they include policies that we've never corrected, such as residential segregation. Again, government created residential segregation. We have never corrected that. We talk about reparations. I would say that addressing those structural forms of racism is a good start toward undoing what government has done to systematically disadvantage people of color. Thank you for that question.
The next question actually lends to that, and they're asking about reparations. And do you have any thoughts on the sustained, how making sustained investments on housing, climate, industry, and making reparations to individuals? Do you think it's an either or, both and? Just wondering what you're thinking about it.
Oh, that's a great question. I get frustrated by our conversations about reparations because, one, we want to study it, right? So we have HR 40, which is important legislation, but it sets up a commission to study the question of whether our government should consider some form of reparation to people of color. And then secondly, reparations tends to be framed as cutting a check to African descendants, formerly enslaved African descendants. It's not as simple as that. To me, a good start on reparations is beginning to address the structural inequities that we have created and baked into our systems. Helping to undo residential segregation and school segregation is a good start. Creating policies and practices that don't systematically disadvantage people of color, addressing over-policing in communities of color. This is a good start. And that doesn't preclude a conversation about monetary compensation, but why aren't we taking the conversation there? These are the things that we could undo right away if we chose to, and don't need to study it. The studies have been done. We know that residential segregation and neighborhood poverty concentration are harmful. And if we know that government was complicit in creating those conditions, is it not government's responsibility to undo that? So that's where I start in the reparations conversation. And I hope that we will be thinking more broadly about repair as a way of repairing all peoples and repairing our earth for the damage that we've done.
All right, this question kind of piggybacks off of the same type of content. If they're asking about what do you think about guaranteed minimum income in the form of maybe direct deposit?
Oh, that's such a great question. I've not studied that issue to a great degree, and I think that there are some really innovative ideas. Dr. Sandy Darity at Duke University has the notion of baby bonds. That what if we established a savings account for every baby born in the country, getting them on a path to savings and providing a level of financial security going forward? That could benefit all of us in the higher levels of investment that we would see as a result. So I'm, while I don't know a ton about a guaranteed minimum income, clearly there are ways to ensure a basic level of financial security, which is critically important for many communities. And that alone would be incredibly helpful during this time of a public health crisis, such as the COVID pandemic, when so many families have been left economically vulnerable, lost jobs, lost wages, family members losing jobs and wages. So we need to be clear that there is a responsibility that we all share to helping each other during these times, and we would all benefit from that kind of approach.
If there was one main thing you think the healthcare sector can focus on, what would it be?
One thing for the healthcare sector, that's a great question. The healthcare sector is an interesting one. I mentioned earlier that we are of course, a market-based system, one of the few Western democracies that still embraces a market approach to healthcare. If you have the resources, you can get the healthcare. We need to be thinking about, even as we're debating things like Medicare for all, how do we create a more balanced healthcare system? And let's be honest, we don't have one healthcare system. We have many healthcare systems. That's part of our structural inequality. We have a healthcare system that serves the wealthy and healthy. We have lower tiered systems. And then we have, in some cases, what I'll call pinto insurance, where folks are barely insured at all. And we have systems that are disproportionately reliant on those forms of insurance. So no surprise, those are deeply under-resourced systems. We have to figure out a way to better balance and allocate healthcare resources where they're needed, because that kind of inequity, again, hurts all of us. So I would encourage folk who believe deeply in market-based healthcare systems to start to figure it out. How can you incentivize for-profit or even nonprofit healthcare institutions to begin to really study and assess how they can allocate resources more fairly and in a way that meets community need while still operating within the kinds of environments that they choose to operate in. So if the question is limited to healthcare alone, I think the biggest challenge for our healthcare system is how do we allocate resources relative to need?
Thank you so much for taking the time to respond to the questions. We have some others, but time is running out. I'm going to turn it back over to Dr. Belgrave.
Thank you so much, Christine, and also Brian. So we just had a wonderful afternoon where we've learned, we've been inspired, we've been motivated. So just thank you so much for spending the time with us. We know how busy your schedule is. We did get a few requests or comments about will this talk be recorded and available, and I believe we put in the chat box that it should be, assuming all the panelists agree, which we can agree to, it will be put on our YouTube channel that Tyler has nicely put the link up to. Okay. So I hate to say goodbye, but you've been very, very generous with your time and answered many, many questions. So thank you again, Asante Sana. And I will say goodbye to you and all of the attendees and the panelists. Good afternoon.
Thank you.